as much information as I have on my slides, there are 3 take-home messages you guys have to know. For those of you who are taking notes and still paying attention, how does it work? Okay, and I'll make sure that you get a lot of good references as well. What is the evidence? And then what are the clinical parameters? What are the clinical guidelines? Okay, so hopefully you'll get those 3 points through my topic. So what is laser? Well, the term laser stands for light amplification by stimulated emission of radiation. And now that you know that, let's move on to the next slide, because that really doesn't mean anything to me. It basically is a form of light that tends to hang around 650 to 1,000 wavelengths. So you'll see, or nanometers. Most of the clinical cold lasers out there on the market are in the wavelengths of about 650 to 1,000, okay, and which is why they're usually red. What we know about laser is that there are 3 properties of all of the clinical lasers out there. Monochromatic, which means one wavelength, right? So white light is a collection of all different wavelengths, okay, and laser is monochromatic. It's directional and it's coherent. So obviously directional meaning it's emitted as a relatively narrow beam in a specific direction. And as you can see, ordinary light coming from the sun or light bulb is emitted many directions. And it's, again, white light is a lot of different wavelengths. And it's coherent, so the wavelengths are in phase in space and time. So laser is usually classified in how much damage, believe it or not, that it could do to your eye if you were to look at a laser. Class 1 lasers are in the visible spectrum, so it's in the wavelength of light that you can see, usually in the red. A laser printer, it would do no damage to your eye if you were to look at it. That's an example, laser printer. Class 2 lasers are like laser pointers, so it's in the visible spectrum, but it may be hazardous if viewed directly for an extended amount of time. Then we have class 3 lasers, and this is where we get into the cold laser or low-level laser therapy, which is what you're going to see most on the market for physical therapy lasers. Class 3A and Class 3B. Now we're talking about they could do a little bit more damage if you were to look right into the light. The power outage of Class 3 lasers is anywhere from about 5 to 500 milliwatts, and that's been proven pretty well in the scientific literature to promote healing. Class 4 lasers are definitely hazardous to the eye, and now we're talking about more power, and we're talking about the stuff that you use in surgery and or for cosmetic reasons and plastic surgery, and not necessarily for therapeutic care of musculoskeletal conditions. So photobiostimulation, take-home message number 1. How does it work? What is it claiming to do? Cold laser or low-level laser therapy is supposed to stimulate healing effects, okay? Reduce inflammation, promote healing, ATP production by the mitochondria in an injured area. This has been studied and proven in scientific research, both in animal and human studies, although more so in animal than human studies, and specifically in cases or studies where the patient population is with tendinopathies, Achilles, patellar, elbow, and plantar fasciitis, and rotator cuff tendinopathy. So there's a reference on the bottom. There are other references in my slide. If you're still taking notes there, I can't necessarily do low-level laser therapy justice based on how much information there is out there, but if you jot down a couple references, you'll be able to make some clinical parameters or set up some clinical decisions in your own practice. But this has all been established to be true. Photobiostimulation, that's what low-level laser therapy is supposed to be for, okay? So there's a couple pictures. I'm trying to make it interesting. But essentially, we're trying to promote healing, right? And we're trying to reduce edema and break up the inflammatory process that can go awry in these musculoskeletal conditions. So there's light, white light, several wavelengths, different colors. Then there's LED and laser. And the difference between an LED and laser, and the only reason this is important is because a lot of the 3B lasers out there are actually LEDs. A lot of the studies are on mixed LED and laser products. LED has the same waveform, it's monochromatic, it has the same wavelengths as laser, but it's not necessarily in sync, as you see between the middle, which is an LED light, and the bottom, which is a laser light. And the evidence is mixed. Basically, half the physicists out there who study lasers say that once a true laser light hits your skin and fascia, the synchronicity breaks up. It hits the skin, it hits the fascia, it goes all over the place. It's really about the power and the wavelength and the properties of the light itself that are making it a potential for healing. So whether you have an LED product or a laser product is not necessarily the most important point. But the fact that it's that monochromatic and a certain wavelength is what really affects the healing potential. So, and then this reference is a really good one, S. Tumilty. So this reference is actually from an entire systematic review that this article published in 2010 is a whole meta-analysis of the use of low-level laser therapy with tendinopathies, which I think is the most appropriate for this talk and for what we do in physical therapy. And as he said, research has demonstrated that both laser and LED are effective, albeit to differing degrees, but in producing that photobiostimulation effect. Okay? So I wanted to go through some research, but all of these references are mentioned in that previous reference, S. Tumilty. So, decreased pain to palpation and prostaglandin E2 concentrations in Achilles tendonitis. This was studied both in human and animal studies, but more importantly, for those of you who actually have a low-level laser machine in your clinic, the dosage was 5.2 joules per centimeter squared, because that's one of the biggest questions. If you actually have either an LED or a laser machine or a combination of LED and laser, what do you do with it? How do you use it on these tendinopathies? So a lot of the evidence that's been compiled now has been brought together in the more recent systematic reviews to actually come up with recommended dosages. Faster wound healing and forearm abrasions, and the dosage was about 8 joules. Some of the studies don't even report what dosages they use, so obviously some of the studies are not necessarily the best to reference here. Laser with therapeutic exercise resulted in decreased pain, improved strength and function compared to exercise and sham laser. Most of the studies that exist, the good studies, the strong studies that exist on low-level laser therapy, this is how they set it up. There's laser, and then there's sham laser, and everybody else gets the same treatment in addition. So they're all getting eccentric exercise, they're all getting stretches, they're all getting potential injections, and then in addition to that, they're getting either low-level laser therapy or sham laser. Some of the studies have quite a lot of subjects, so they're stronger. Some of them are blinded, some of them are not. But essentially, low-level laser therapy has been established to reduce pain and improve function in primarily tennis elbow, Achilles tendinopathy, patellar tendinopathy, and rotator cuff tendinopathy. So this is actually a table out of Tumilty's meta-analysis, his systematic review, listing all of the strong studies that show positive effects of low-level laser therapy. And most of the wavelengths of the low-level laser in these studies goes anywhere from 650 to 1,000 nanometers. Okay, you can see that it's all done on shoulder, tennis elbow, Achilles tendinopathy, and these all show positive effects, again, in the use of laser plus therapy versus sham laser plus therapy. And based on all of the evidence and all of the reviews and going through the studies and figure out which have the strongest, best studies and in this whole systematic review, the author found that in the 4 most common tendinopathies, epicondylitis, rotator cuff, Achilles, and the wrist, this is what he found. In the parameters, all of the studies he found, basically you want to be in about 650 to 1,000 nanometers. So most of the class 3B lasers on the market, those are the wavelengths that are produced. You want to have about anywhere from 3, if you go read through it, anywhere from 3 to about 6 or 7 joules per centimeter squared for your dosage of energy. And that's important because when someone comes in and you have a laser in your clinic, you have to know how much energy to actually give them, how much phototherapy to actually give them. A lot of newer topics talk about class 4 lasers and more power. If you go into more than 500 milliwatts and deeper wavelengths, and how much you're going to penetrate, and are you really causing that photobiostimulatory effect in these tendons? Class 3B lasers aren't strong enough. They have LEDs, not true laser lights. But here's the bottom line. If you're trying to get to an Achilles tendon, say for like a 25-year-old female athlete, you really don't need to get 10 centimeters deep, right? You don't necessarily have to go that deep. If you have a class 3B laser on the market that's potentially LED and laser light, and you can emit anywhere from 3 to 6 joules per centimeter squared, that's a decent product to have, okay? So strengths and weaknesses of low-level laser therapy. There's really no consensus yet on appropriate dosage, but the studies have existed for over 30 years, and now we're getting into the meta-analyses and the systematic reviews. And overall, for the use of tendinopathies, I would say anywhere from about 3 to 7 or 3 to 8 joules per centimeter squared is fine. So as long as you have a product that emits that, then it's a nice adjunct to your therapy when you're doing everything else. Class 3 lasers do have a set power underneath 500 milliwatts. They can only emit up to a certain amount of energy, and newer research is slightly positive towards having higher powered lasered with pulsed wavelengths, so you still get the same amount of energy, but without so much power, so without so much potentially damaging effect. Class 4 lasers is what that newer evidence is focused on. Class 4 lasers in the marketplace go for about $25,000 to $30,000, whereas the Class 3B laser that might have LED and laser lights is usually about $5,000. You can find $5,000 to $8,000. So if you're making a decision about whether or not to get laser in your therapy, it does work. It has photobiostimulatory effects. There's plenty of evidence to show that it works, and you don't necessarily have to go with one of these high-powered, expensive machines. And there's a picture of all the different. There's so many different lasers on the marketplace. Basically, the take-home message: it does work. When you're doing physical therapy for someone trying to avoid surgery, chronic tendinopathies, I think about all the patients that we actually put laser on. We're not doing anything else. I'm not saying use your laser therapy in order to treat rotator cuff tendonitis. You still have to look at the neck. You still have to look at the shoulder blade. You still have to address all the other issues. Do your eccentric exercise. Make sure your manual therapy, you're gaining their range of motion and joint mobility. But low-level laser therapy, if you have access to it, might be a nice adjunct to that. And there aren't any harmful side effects when you stay within those 3B lasers that only emit so much energy with so much power. And that's about it. That's it. Thank you.